Okay, in this segment, we're going to talk about calcium disorders. And actually, calcium is very related in the body to phosphate. And the calcium and phosphate homeostasis is kind of parallel. So we eat them with food, we take them with food, we absorb them from the GI, they circulate in the blood, and the excess is stored in bones. And finally, we get rid of them in urine. So this is the life story of calcium and phosphate. We take them with food, we absorb them from the gut, they circulate in the blood, we store the excess in bones, and we excrete them in urine. And the hormone that controls calcium level in the blood in particular is a hormone that comes from the parathyroid glands and is known as the parathyroid hormone. Where is the parathyroid gland? The name implies it's next to the thyroid. It is parathyroid. And actually, if this is the thyroid, on the posterior surface of the thyroid, we have 4 nodules, and they are, I'm drawing them as dots just to remind you that the parathyroid exists behind the thyroid, on the posterior surface of the thyroid. These 4 nodules are the parathyroid glands, 4 parathyroid glands, and they produce a hormone known as the parathyroid hormone, and sometimes we call it parathormone. And the parathyroid hormone is the calcium fan. The parathyroid hormone has only one function in the body: to increase potassium in the blood. Sorry, to increase calcium level in the blood. The parathyroid hormone increases calcium level in the blood and decreases phosphate. Calcitriol, which is nothing but the active vitamin D. Calcitriol is vitamin D. Calcitriol is vitamin D. It increases calcium and also increases phosphate. But the parathyroid hormone, and this is what I want to focus on, the parathyroid hormone, it increases calcium in the blood and decreases phosphate. How does parathyroid hormone increase calcium in the blood? It enhances calcium absorption from the gut, but this is not the major effect of parathyroid hormone. Parathyroid hormone, it steals calcium from the bones to take it to the blood. So this is how parathyroid hormone elevates calcium level in the blood, by stealing the calcium that is stored in bones to pour it into the blood. So yes, parathyroid hormone makes the blood full of calcium, but it makes bones empty. No calcium in bones, and this weakens bones. This weakens the bones. Okay, so when we talk hypercalcemia, the normal level of ionized calcium is almost 4 to 5, but the total calcium, or the non-ionized, is 8 to 10. This is the most famous calcium level, up to 10. That's the most famous calcium level. Hypercalcemia is when the total calcium level exceeds 10 milliequivalent per deciliter. That's hypercalcemia. What are the clinical manifestations of hypercalcemia? There is a mnemonic that helps you memorize it. When you have too much calcium in the blood, remember this mnemonic: stones, bones, abdominal groans, and psychiatric overtones. Too much calcium in the blood: stones, bones, abdominal groans, and psychiatric overtones. When you have too much calcium in the blood, hypercalcemia, this too much calcium will go to the kidney, because we get rid of calcium by peeing it. And when you have too much calcium in the kidney tubules, some calcium can get deposited, causing nephrolithiasis which is the fancy term for renal stones. So nephrolithiasis is renal stones, kidney stones. And this too much calcium in the blood, where does it come from? It comes from bones, because the parathyroid hormone, which is the major cause of hypercalcemia, it has stolen calcium out of bones. So you start getting bone pains, and your bones become fragile, and they might even fracture. And that's the second word in the mnemonic, bones. And for some unexplained, for some unknown reason, patients with hypercalcemia develop abdominal pain, and that's the abdominal groans. And they develop some psychiatric problems, depression, anxiety, confusion, some psychiatric problems. And also they have constipation, and they show some EKG findings, short QT interval. And there are some additional manifestations. The most important one is dehydration. So what are the etiology of hypercalcemia? By far, the most important cause of hypercalcemia is increased parathyroid hormone, because the parathyroid hormone is the major calcium fan. The more the parathyroid hormone, the higher the calcium level. So hyperparathyroidism is the major cause of hypercalcemia. Whether this hyperparathyroidism is caused by adenoma of the parathyroid glands, or hyperplasia of the parathyroid glands, or even carcinoma of the parathyroid. Carcinoma of the parathyroid gland is a functioning cancer, Not all cancer cells are functioning, but carcinoma of the parathyroid is a functioning tumor. So you get excess parathyroid hormone. Another rare condition, but it happens, is in very terminal malignancy, in very late stages of any cancer anywhere in the body. A protein comes out from these very malignant cells, and this protein is known as the parathyroid hormone related protein. Parathyroid hormone related protein. A protein comes out of the highly malignant cells that resembles the parathyroid hormone in structure and function, and this protein coming out of the highly malignant cells result in very high calcium levels. So these are the two major causes of parathyroid hormone excess, and they are the two major causes of hypercalcemia, hyperparathyroidism, and terminal malignancy. And the rest of the table summarizes other causes of hypercalcemia. If you have bone resorption due to whatever reason other than the parathyroid hormone, or if you have vitamin D excess or excessive dietary intake of calcium, some drugs like thiazide diuretics can cause hypercalcemia, and we have some rare miscellaneous causes. So these are the so the combination of primary hyperparathyroidism and the parathyroid hormone-related protein secreting malignancy and osteolytic bone metastasis are collectively responsible for about 90% of all clinically relevant cases of hypercalcemia. So how to differentiate between malignancy as a cause of hypercalcemia and hyperparathyroidism as a cause of hypercalcemia? When we look at the symptom severity, the hypercalcemia of malignancy is usually severe, but the hypercalcemia of hyperparathyroidism is usually mild. The acuity of onset in terminal malignancy, this hypercalcemia occurs rapidly, days to weeks, but in hyperparathyroidism, it takes weeks to months. It develops slower. The physical examination is, of course, that terminal malignancy is usually abnormal, whereas the physical examination in hyperparathyroidism is usually normal. We notice this malignancy, hypercalcemia, usually in inpatients. They are terminal cancer patients. They are usually hospitalized. And when malignancy is really very late, we start noticing hypercalcemia. But hyperparathyroidism is kind of an outpatient condition. When we do numbers, the serum calcium, when it is increased by malignancy, it usually exceeds 12.5. You remember the normal level is up to 10.2. When it exceeds 12.5, that's usually malignancy. When it is somewhere between 10 and 12.5, this is the primary hyperparathyroidism. The most important thing I want you to know about treatment of hypercalcemia is hydration. Hydration with normal saline. Okay, now let's move to hypocalcemia. Remember, when calcium goes down, it takes the shelf down. Remember, when calcium goes down, it takes the threshold potential down. So when you have hypocalcemia, the threshold membrane potential is less, and the shelf becomes closer to the bed. Whenever the shelf and bed come closer, what happens to excitability? Excitability increases. When two are kissing, the closer they get to each other, the more the tension and the more the excitability. So in hypocalcemia, the excitable tissues become more excitable, and we develop tetany, which is the repetitive discharge of peripheral nerves after a single stimulus. And the symptoms of tetany are perioral paresthesias, muscle stiffness, spasms and cramps, shortness of breath, and diaphoresis. And the signs of tetany, we have the Chvostek's sign and the Trousseau sign. You can read them. And then with more hypocalcemia, you get seizures, hypotension, and even sometimes you get psychosis, and the EKG findings, prolonged QT interval. The etiologies of hypocalcemia is hypoparathyroidism, as in status post-surgical thyroidectomy. In the surgery of radical thyroidectomy, if the surgeon wants to remove the entire thyroid, and it happens that the surgeon removes the parathyroid with it, what happens to the parathyroid hormone? It's going to go down, and immediately what happens to calcium level? It's going to go down. And these patients, when you awaken them from anesthesia, because the very low, acutely low calcium levels, they develop acute tetany, muscle spasms, and when the muscles of the vocal cords are in spasm, the vocal cords get in spasm, and these patients cannot inhale, and you have to re-intubate them again or even do tracheostomy for them. So when you remove the thyroid, the patient develops acute hypoparathyroidism and the calcium level drops. Vitamin D deficiency is another cause of hypocalcemia, low dietary calcium, and there are some miscellaneous causes of this hypocalcemia. Treatment of hypocalcemia, guess what? Calcium. And this ends this segment.